Right. So there are many pathways that are identified in laboratories, in vitro and in animal studies, especially with all the genetic manipulations we can do. But there are clearly two, not only more advanced in our knowledge, but also really dominant pathways. One is what we call the Wnt signaling pathway, and the other is the parathyroid hormone receptor signaling pathway. There are at least two compounds that are currently in clinical trials. Both are in phase 3, one a little more advanced than the other one. They have barbaric names, romosozumab for the Amgen compound and blosozumab for the Lilly compound. But what is really very striking and exciting from a scientific point of view and clinical is that they both have very, very identical effects, even to things that we thought were variability of data appear to not be variability of data, but real biological responses. And that opens, of course, a lot of interesting questions that will need to be addressed in the future, both in humans and in animal studies. So the other pathway is activation of the parathyroid hormone receptor with parathyroid hormone, or actually a fragment of parathyroid hormone called amino acids 1 to 34. It's called teriparatide and has a commercial name Forteo or Forsteo. So it's already on the market. It is a very efficient anabolic drug, but it is also limited by two factors. One is in a way similar to what we observe with Wnt signaling, although it occurs at a slower pace, is that over time it appears to lose efficacy, if you want. The responses go up for about 12 months, let's say 12 to 18 months, then come down over time, and we do not understand why. And the same questions have to be asked as we did for Wnt signaling. But the major limitation of activation of the parathyroid hormone receptor pathway is the fact that unlike Wnt signaling, which inhibits resorption, that pathway activates resorption and increases the destruction of bone in parallel to increasing its formation. So over time, you still gain bone density, at least for, let's say, 24 months, which, by the way, turns out to be the authorized lifetime limit of use of these compounds. But that you would gain much more if you prevented this secondary, or parallel, I should say, increase in bone resorption that this pathway induces. So and I presented some, a number of approaches have been tested and are being tested to keep the anabolic side and prevent the resorption side. And I cited, if I recall, 3. One is the treatment with a higher dose, actually almost 3 times, instead of giving it on a daily basis as teriparatide is given normally, to give it once a week. And that's been tried in Japan, not worldwide yet. And in Japan, the studies show striking maintenance of the anabolic effect, at least to a certain degree, while prevention of the resorption effect. So it's very interesting for multiple reasons. Also, they showed very significant reduction of vertebral fracture incidence. So it's really promising in a way. It also has other advantages, which is that, of course, it would be a cheaper treatment because you use far less drug. The second approach is a combination of both teriparatide and an anti-resorptive, and particularly, so it can be done with bisphosphonates, and there are studies showing that, but more mechanistically relevant is with denosumab, which is an antibody to a molecule called rank ligand, which is inducing resorption and is induced by a parathyroid hormone. And the 2-year data just came out in the Journal of Clinical Endocrinology and Metabolism, and clearly demonstrates that the addition of the two treatments improves tremendously the gain in bone density everywhere, but strikingly at cortical sites. So it should translate into reduced fracture rates, but we don't know yet. And the third is a small company has been using, instead of parathyroid hormone, another gene called parathyroid hormone-related peptide, which is not a hormone, but a local factor that regulates also bone formation. And the reason why they did that is that this molecule, which has slightly different amino acid sequence, increases bone formation as much as parathyroid hormone, but seems to have less impact on the resorption activity. And so they have done already phase 1s and 2, and they are currently in phase 3. So within the next year and a half, we'll have 3 or 4 major phase 3 final results. So it's going to be very exciting for our field. 2 in the Wnt signaling pathway, 1 with a molecule I didn't discuss called odonacatib, which is an anti-resorbing agent of a new class, and abaloparatide, that's the name it has, this PTHRP-based molecule. And so far, their data seem to indicate superiority in terms of gain in BMD, in part because of a purely anabolic effect, and in part because of less negative impact through resorption activity.
My talk was focusing on how what we know, scientifically speaking, about the bone-forming agents, the so-called anabolic agents, translates into the clinics, how we use and which potential future uses we can contemplate for anabolic agents. Teriparatide can be a good option for treating patients at very high risk. And the reason for that is that as of today, we know that these very high-risk patients quite often may fail to the treatment with the oral agents that are the common treatment for the disease. Oral agents, mainly oral bisphosphonates, cannot stop the fracture cascade in patients that have suffered, especially recently, a previous fracture. Also in patients of more advanced age, or patients taking glucocorticoids or other drugs that can limit the efficacy of the agents in reducing the risk of fractures. So in these high-risk individuals is where we can use as a first choice the treatment with an anabolic to in some way induce a remission of the disease, revert part of the deterioration in terms of bone mass and bone structure. And the only possibility available we have as of today for trying to compensate for this very large increase in risk in advanced stages of the disease is the use of anabolic agents. Yeah, this is an area of interest because no drug cures everybody. In osteoporosis, the situation is very similar. The available drugs reduce the risk, but not to a point that is similar to the risks that we see in young, healthy individuals. In other terms, the fragility or the loss of strength induced by osteoporosis is only compensated in part by the available agents. This drives to the problem that patients, even taking oral drugs for osteoporosis, they show fractures. And this is something that is extremely inconvenient for the patient and raises a big challenge for the clinician, because the drug is not doing what it's supposed to do. It's preventing the occurrence of new fractures. Although it's not terribly frequent, it has been estimated that about 3.5 to 4% of patients per year suffer fractures in spite of taking drugs with a good level of adherence. In those cases, there is no clear evidence and no clear guidelines for the clinicians on how to behave. And one of the possibilities that has been contemplated in the currently available recommendations is to switch the treatment from these oral antiresorptives that have not been enough powerful in stopping new fractures from occurring to a potent bone-forming anabolic agent. And this is one of the common practices we see in our everyday activity. In many areas of medicine, we combine drugs with different mechanisms of action. For example, in treating hypertension, classically in treating severe infections, we use the combination of 2, 3, or even more different agents that attack the problem through different pathways and different mechanisms of action. The same can be translated into osteoporosis. We have two main groups of drugs: bone-forming agents, agents that promote formation, but at the same time they increase resorption, so there is a positive aspect in terms of gaining bone quantity and bone strength, but it's also a limitation because the associated increase in resorption limits the net benefit of the anabolic treatment. And it's in these cases where it's being tried and is under development, is an area of very active research as of today, to combine the best of two worlds by using a potent forming agent and at the same time a potent selective inhibitor of bone resorptions. You can induce the good and stop the bad aspect of the bone balance. And along these ways, you can improve very much the performance of the treatment in terms of gaining mass and gaining strength. But this is the critical point that remains to be demonstrated, that the combination of two different drugs with two different mechanisms of action is reflected in an additional benefit in terms of reduction of the risk of fractures.
If I may kick off, I think one of the important messages, I think, for the people in the audience and people in the bone field is what has been shown there, the significance of understanding the molecular and cellular biology of bone, to be able, first of all, to identify new therapeutic targets or diagnostic targets, but also to understand that if you are in a later stage when you are able to test in animal models or even phase 1, phase 2, to understand what's happening and what you are seeing on bone level, to understand why you see only a temporal effect in increase in bone mass and not a decrease in resorption or an increase in resorption. I think that was one of the important points of this morning's session and the presentation by Professor Baron. And I appreciated very much the limitation approach he took, to really carefully mention, okay, we have these two, the Wnt signaling and the PTH, which give more bone, but what are the limitations? And also there, understanding molecular biology and cell biology is key. That was for me an important point.
Yeah, I totally agree, and I think this becomes of particularly important at this point because to date on the anabolic end we had only one major approved medication based on PTH. But now we're entering into the phase where we have actually, fortunately, a number of new drug candidates that are being explored in part already in phase 3 that will open up much wider possibilities to treat our patients. And I think this is really coming at a very good time because we have to appreciate we're talking about a chronic disease, a lifelong disease. We typically treat, particularly with the anabolic agents, we are only allowed to treat for 2 years, but then we still have to do something. So having new candidates coming aboard is very important. And then making clever use of those requires definitely in-depth understanding of their strengths and limitations. I think the way the ECTS program is put together, and this symposium, for example, is that you have one basic science talk and then a clinical talk, because it's really to understand how does the basic science really result in specific recommendations for the clinical end. That is the strength, and that's where we want to make some progress.
I think that's also the importance of this meeting, that the MDs and really the preclinical basic scientists are in one room, in one meeting together, and that they speak a common language, because I think there you can make progress, not on separate meetings for basic scientists and MD meetings. This is where you have the mix and where you can stimulate each other and come up with ideas. And I think the bone anabolic session was really a good example where
Absolutely.
a very great bone scientist can present from the molecular view and the cell biology view what can happen in a clinical context.
One important question, if we sort of make the transition from the basic aspects to the clinical ones, is the combination. And Hans, what is your thinking of how to combine these? Can we combine anything? I think after today's session, what Adolfo showed us, that's definitely not the case.
No, you mean combination treatment?
Combine parallel.
Yeah, I think there we need the understanding of how they are working, because I don't think you can just combine everything. Adolfo showed that perfectly. You need to know how they work so that you know, should I give first this one and then that one, or can I give them simultaneously, or give them for a certain period and then stop. Yeah. Therefore, we need to know how things work, and I think PTH is a nice example. We know already for years that if you give PTH to cells multiple times, there is some kind of desensitization. Mm-hmm. And apparently that's also now seen, as has been shown this morning, when you give patients PTH and you stop for a year, then still, and we don't know why, there is a less strong response in the second stage of PTH. And therefore actually we have to go back to older data on PTH and desensitization. And again, maybe I'm repeating myself, it's important to understand how it works. And then you might be not that surprised if you see the desensitization. Now, this is one example. And I think it also shows that by knowing this, you also can know, if you know the cell biology, indeed, should you have anti-resorptive? Maybe immediately or wait a little bit. Mm-hmm. But there is still, there was not a firm conclusion by Adolfo that there is already a combination, but I think it's still open there, and what he showed, we need more data. Yes. Some data are positive, but it's limited at the moment.
Yes. Yeah. The other point to consider when we talk about parallel treatment is, of course, that by doing that, we may very quickly exhaust our possibilities of treating. And again, coming back that we talk about the chronic disease, lifelong treatment potentially, that may not be the best strategy. So you pick your choices wisely, one step after the other, and to know what to do first and what to do next, I think is not trivial. I think from a scientific point of view, you might say, okay, first you have to raise the level of bone mineral density and structure to the highest level and then maintain it. But in a practical setting, we have to start with the anti-resorptive agents. But hopefully, maybe if we have more and more options in the future, we can indeed pursue both aspects.
What I want to bring up also, maybe a little bit shifting away from discussing the combination therapies, is that also we should not forget that bone is not alone. Bone is there together with the bone marrow, with the hemopoietic system, with the cartilage, with the muscle, and we may touch upon muscle later, but that if we do something to the bone and the bone mass and the activity of bone cells, we may indirectly or maybe even directly affect the hemopoietic system, because the bone surface is really important for the hemopoietic stem cell, for surviving, but also for controlling the differentiation of the stem cell and giving rise to the full immune system. So that's something we should really take into account, and shows again what I said, bone is not alone, and maybe there are other examples. And one of the things, if I may follow up, is the diagnosis and risk assessment. Mm-hmm. We have a couple, and we talked about that earlier, that we have markers, but yeah, they show maybe only a fraction of the whole picture. And I think that there was a session on this meeting on extracellular vesicles, which is really, if you look in the scientific world, an exploding field, that cells and tissues secrete little balls containing RNA and proteins that reflect also the metabolic state of that tissue, of that cell. And in other fields already, those little vesicles are being developed and investigated in relation to disease state. And I think that's also showing why that session was here on the meeting, to bring it to the bone field, that maybe these vesicles might lead to novel diagnostic markers for bone metabolic state. And I think there we may hear more in the future.